corporations currently fund insurance plans for their employees. Now, the plans are requiring more and more that the employee put in a share of that, but employers are still on the hook for a large component of health insurance, and they're concerned because they are seeing that those costs are excessive, and they are thinking that within the next 5 to 10 years, providing health benefits just won't be sustainable. They're desperate in the corporations, the businesses that I have worked with and talked to are all very concerned about their ability to care for their employees. So I set about trying to figure out how it is that we on the healthcare side can help come up with ideas for how employers can continue to work to care for their employees, to provide health insurance and really to help their employees and the communities in which the businesses exist, help improve the health and the well-being of the employees and the communities. So 225 billion. That's the cost of the major drivers of health on the economy every year. These are things that are by and large preventable and addressable, and yet the costs are overwhelming. We also see that the drivers of health are often beyond what the healthcare system can do and does, quite frankly. Clinical care, this is for those of you who've seen this number before, this comes out of a study out of Wisconsin around the idea of drivers of health. It's often quoted. It's pretty accurate that clinical care really accounts for a minority of what drives health. Much more important are the physical environment, health behaviors, and then social and economic factors. And in that, we have to include things like the impacts of poverty, of racism, of gender inequality, on not only preventing people from achieving their goals, but really driving causes of poor health. You can see what we commonly refer to as social determinants of health. It's a broad range of factors in people's lives. There have been a number of efforts over the years to address issues of employee well-being. The two big buckets are employee assistance programs, or EAPs, and workplace wellness programs. Unfortunately, the evidence for the benefit of these is lacking. Oftentimes, these benefits are administered by a third party. The third party may not know the business, it may not know the employees, the third party may not even be local. So you have a third party of individuals who are set out to help employees achieve wellness, but they often know nothing about the employees or the communities that they come from. With regard to workplace wellness specifically, a number of studies have been done that just demonstrate that there's really no benefit to the workplace wellness programs. EAPs are slightly more successful, but they're vastly underutilized. The estimate is less than 10% of eligible employees will use an employee assistance program. Some of those reasons are a lack of trust in the program, a lack of trust in confidentiality, or just the fact that they don't know these people. These people aren't from their community. They don't necessarily share the same experiences. So that's where this project comes in. Again, there's Steve Lesky, looking helpful as ever, and the Cambia Foundation, in its whole person care model, was generous enough to fund our work. which began as a community collaborative that included a community-based organization that works with community health workers, with the Department of Family Medicine, and with a benefits coordinator, health benefits administrator, who has a real interest in figuring out how to make employee benefits more useful to employees by delivering services that really meet their needs, especially around social determinants of health. The project began as an idea, and the advisory committee helped to develop a model that we felt was potentially usable by a local company. We were trying to figure out what company we would approach. And then it became apparent to us that OHSU, Oregon Health and Science University, where I work, being one of the largest employers in Oregon, was actually a great place to start. And to my surprise and really to my delight, OHSU has been incredibly receptive to this. They have offered resources, have engaged at every step of the way to try and figure out how to bring this program into a pilot. Initially, it started out as an employee needs assessment survey. And because we are, trying to identify a group of employees that are most representative of the broad diversity at OHSU, both from a demographic perspective as well as a financial perspective, we decided to work with AFSCME, which is our local union that most of our OHSU employees belong to. It is not a union project per se. It's not part of the collective bargaining or of any of the discussions between administration and the union. It's purely that we had a relationship with some of the union leadership and felt that the membership of the union was broadly representative of the employees at OHSU. So this was an IRB approved research study. We surveyed about 7,000 employees. We had a response rate of about 28%, which was fantastic, much more than we were hoping for. And it spanned more than 20 departments, people making $15 to $40 an hour. And so along with questions about demographics and salaries and wages, what we asked was, what areas do you need support in your life? And the top 4 areas were, you can see here, counseling and emotional support. And I should say this was a survey that was put out in January of 2021. So it's among or amidst the pandemic. So unsurprisingly, the biggest need was counseling and emotional support. But second to that was eating healthier, losing weight, or quitting smoking. And then taking care of chronic health problems and food, housing, financial resources. So things that you imagine coming up in discussions around social determinants of health. Now, OHSU, like most big organizations, has an employee assistance program. It has counseling and peer support, has financial coaching, it has health coaching. But again, like other big organizations, these are vastly underutilized. And a recent survey done by our HR department to try and figure this out came up with a lot of the same factors. I don't trust that this will be anonymous. I don't trust that this is not directly linked to my employment. And often it's the people who are involved with, on the EAP end, don't talk like me. They don't look like me. They don't have the same experiences that I do. So I want to pause for a second, and I want to give you a scenario. Imagine the community where you live, a new restaurant opens up, and it's a hip restaurant, trendy, kind of fancy. It's outdoor seating because it's the pandemic. You want to go eat at this restaurant, but it's pricey and you don't want to spend a lot of money on something, that you're not going to like. So you try and find advice about this restaurant. And you have 2 choices. You can ask a friend of yours who is a local chef. He's lived in the community all his life. He's got 15 years of experience being a chef in the community. He actually knows the owner of the restaurant. Or you can trust this guy. So food guy 2635 is not an actual person, just so there's no breach of confidentiality here. Given those two choices, who do you think you trust more? And that is the basis of community health workers, why they're so powerful in their jobs, why they're often so successful in what they do is they're from the communities that they serve. They share lived experiences with the community members. They know the communities, they know the resources that are available, and not just a list of places to call for, say, housing assistance, but they know that if you're going to go, don't go on Thursdays because it's always the busiest on Thursdays. Wait until Friday morning. And actually on Friday morning, they have free donuts that Kim sometimes brings in, right? So it's more than just handing you a packet of numbers to call. It's really about knowing how to navigate the system, which often, let's be honest, is both Byzantine and convoluted. Back to our survey, we asked if OHSU made community health workers available to employees, how likely would you be to use those services? We were expecting no more than 30%. And what we got back from all respondents, that's across wages, was that above 50% had some interest, expressed some likeliness to use this service. When we drilled down into race and ethnicity, self-identified race and ethnicity, and wages and salaries, we found that people making less than the median wage and people who self-identified as from the BIPOC community, the number of people interested in working with community health workers went up to about 75%. I was fortunate enough to look through an attendee list last week. I understand it's changed some, but I saw that some of you actually are community health workers. So again, if anything I say here doesn't connect with your experience, please feel free to correct me. But community health workers are, as I said, members of a community. They work in the community that they serve. They work to help individuals and their families. And this is critical because often things like employee assistance programs, workplace wellness programs are available to employees, but not their families. And you really can't wrap your head around the idea of dealing with something like food insecurity or housing instability and only helping one member of the family, right? These are things that encompass the entire family. They improve health and well-being, and they empower communities to meet their goals, not just around wellness, but really around getting their needs met. They're fierce advocates, and they often help with community organizing around specific needs. They, again, come from the community. They often share one or more demographic factors or experiential factors. They often come from and work with underserved populations. And I think paramount is that the services they offer are always confidential. In Oregon, we actually certify community health workers as a recognized health provider. They cannot independently bill for services, but they can have their services reimbursed by working with a clinic or another licensed medical professional. They're being used increasingly by clinics and by health systems, not just outpatient and not just federally qualified health centers, but really hospital systems as well. And they've got a broad scope of practice. I touched on a few of them, and you can see here all of the things that they're able to do. I'll share these slides afterwards so you can take your time to look through this. And they're effective. Obviously, you would not expect that community health workers would be as popular if they weren't delivering a return on investment, right? So as far as health goes, you're seeing improvements in the metrics that we look at, things like diabetes control, cholesterol, blood pressure. Mental health seems to be improved. There's better adherence to behavioral changes. So again, addressing the needs that were identified in the survey, eating more healthfully, quitting smoking. There is a return on investment. Pardon me, just a moment. I'm going to move because there is all of a sudden some construction outside my window. So pardon me, Zoom life. I don't want to make you all dizzy, so I'm going to pause the video for a second.
No problem, Dr. Frank. It probably sounds worse on your end than it does on ours.
Oh, well, good, good.
Thanks for your nimbleness here.
Sure. It wouldn't be a Zoom meeting if I didn't get up and move at least once. I was actually, so I'll talk about this a little bit later, but OHSU's president has been engaged with this work. He's supportive of what we're doing. And I was having a discussion with him about this, and my dog started going crazy in the background. So here I am on the video conference with our president and having to get up and wander into another room. So it's become part of life. You can see there's a return on investment with community health workers, not only from things like reduced hospitalization and reduced ED, emergency department utilization, but also on the factors of health that we mentioned. And then it improves care as well. And these are the things that we talk about when we talk about triple aim. So individuals feel that their care is better when a community health worker is engaged. That led to a conversation between a couple of individuals, including me, about how community health workers could be engaged with employers and help employees. Getting back to what we were talking about earlier, the costs that employers put into health every year, they're looking for ways to reduce their costs. And quite frankly, most employers are looking for ways to keep their employees healthy and keep their employees happy, especially now in a job market that's so tight. There is quite a bit of interest in employee retention, employee loyalty. So the idea of having community health workers in the workplace, I think is a way to not only address those concerns of employers, but much more importantly, to meet the needs of the employees in a way that they will find, hopefully, to be more palatable, more interesting, more helpful than the traditional employee assistance program. Again, by offering services that are more culturally congruent, that are more appreciably anonymous, and that really help the entire family. And let's be frank, that help employees identify ways that they can take control of their own health, of their own experiences, and advocate to their employers about things that they need. As we've thought about different models, the main three that we've come up with is the idea of and embedded within the HR department. So the community health worker is actually an employee of the company. The benefit of that is it's all done in-house, but I think there's a lot of downsides. The trust factor goes down. Quite frankly, the HR departments that I've talked to don't want to take on the responsibility of dealing with these employee social determinants needs, other community needs. Another option is to have the community health worker themselves be a contractor. They are then external to the company, but the payment gets complicated. There's a lot of risk that's taken on by the community health worker. And quite frankly, community health workers thrive when they have a liaison between themselves and the group that they're working with, when they have access to training and when they have access to other community health workers, ideally who are doing the same sort of work. So the third option that we've hit upon, and I'm quite certain there are others, but the one that we've hit upon is to find a contracting organization that works with community health workers to take on the responsibility of hiring and training the community health workers to provide support for the community health workers specifically, and to be the interface between the CHW and the business. Now, we're only beginning to build this pilot, so we don't have any empiric evidence that this works, but based on the needs of both employers and of the community health workers, we think that this is going to be the model that will be most productive, and that will provide the best outcomes for employees and for the community health workers that are helping them. As far as the ideal pilot, we wanted to find a region and an employer that is that has access to claims data, that has a large enough number of employees. The number that I've often been quoted about the caseload for a community health worker is about 75 people per caseload. I suspect that varies depending on what they're doing, how much interaction they're having, but you need to have enough employees that a sufficient percentage of them will try this model and will provide enough for the community health worker to make it worthwhile for them. There has to be some homogeneity because, as we said, the community health worker comes from a community. So ideally, there's a large enough representation from that community, be it geographic, be it demographic, that it can support a community health worker working with those individuals. There obviously need to be sufficient community resources. I don't know what you all do, but I know that some of you are in healthcare. And if you are like me and trying to find community mental health for your patients right now, it just is non-existent. So what you don't want to do is have a community health worker working with a group of people for whom, for example, housing is the biggest need in a community where there are just no housing resources. It's not going to be successful. You need to have a clearly defined need, which is part of the reason that we undertook our needs assessment. You need to have employers that are willing, and you need to have community health workers that have both supervision and support. Most importantly, I think you need to have buy-in from the employees. This needs to be a ground up process, not a top-down process. We've seen far too many times that top-down employee benefits just are both underutilized and often not helpful and may even re-traumatize people who really don't benefit from those programs. I won't spend a lot of time on this, but the thing that we're working on right now is we've gotten support from the university for this research. We are now going to begin the pilot, the planning phase. We have reached out to our Center for Diversity and Inclusion, as well as our employee resource groups to advise us on this process. We will also be hosting focus groups of employees that, based on our survey data, are most likely to utilize the community health worker services. And again, really make it a community-led, community-developed pilot. Once we've done that, we hope to pilot this with a subgroup of employees. And then if we can demonstrate benefit, and again, the metrics will be decided upon by the stakeholders, then hopefully we can develop a program that can be scaled from that point. So I sort of covered this. Our advisory committee is going to be leadership from the employee resource groups, from our Office of Diversity and Inclusion, from representatives of the various employee groups, from our Human Resources Department, and from community health worker organizations. We're fortunate in Oregon to have a statewide community health worker association. So hopefully we will be partnering with them as well. And then, of course, our research team. With that, I really want to use the majority of this time for discussion. And I'm really happy to answer any questions I can. I'd love to hear from you, thoughts, reflections. corrections, anything that comes to mind about this idea or really about any of the topics that I brought up. So I'll pause. I'll turn it back over to Nick, and I'm happy to answer questions or comments as needed.
Terrific. Thank you, Dr. Frank, for setting the stage and the work you're doing primarily, of course. I have a number of questions that I promise are less interesting than the questions in the room. So please either jump in the chat or raise your hand and we'll come to you. I'm not sure I understand. One question I have top of my list here for Dr. Frank, and knowing some of the folks in the room here that are focused on the workforce side of things in any number of segments within healthcare, but thinking about the community health worker perspective. Dr. Frank, enter the room. What challenges and opportunities do you see in the workforce development space with respect to community health workers, and how can this model help maybe alleviate some of those great concerns that I know we're seeing in Washington State and certainly in Oregon everywhere, right? How maybe can state entities, and Corey, I see your hand up. I know this is a space that you all have been in, Andre, as well. Corey, let's come to you first and then to Andre.
Well, I guess typically whenever this discussion of integrating community health workers into a program comes up, I think sadly, one of the things we have to address, right, is how we pay for them. And I think one of the other big considerations is that I think we're still in a place in healthcare in the way that we use community health workers and other clinical assistants where those valuable services, because they're not, what they're providing is not all direct clinical care, it's not valued the same. And so our mechanisms to pay them and to pay them living wages are better, and actually have methods of upward mobility and professional development themselves, like the things that actually create quality employee experiences for the community health worker themselves are not in place. And so I think anytime we're starting a new project and thinking about, utilizing these valuable services that somebody with this kind of lived and community experience can provide, I always wonder, how are we creating a system that really truly values that service that they're providing?
Yeah, Corey, I mean, you make the essential point that undergirds and is one of the other barriers that we certainly have uncovered in Cambia Grove's work, and not a new point, a revelatory point that we're unearthing, but the misalignment of incentives across healthcare is just structurally so challenging. And not to just plug our stuff too much, but we'll put some things in the chat here and work that we've done in the value-based space, just for folks' reference. Would anybody want to comment further to Corey's answer, or? And Andre, I don't know if your question or answer comes to that in that context, but please.
Yeah, it actually does a little bit. So yeah, I can work on that. First of all, thank you so much, Dr. Frank. I will definitely be getting in touch with you. I'm here in Portland as well. So when I saw you at OHSU, I was like, oh my God, this is so exciting. One of the things I think that you brought up that's real critical is that we think, whenever we say healthcare, we always think medicine. Mm. And I think that's the problem that medicine has, is that they're expected to do things that just aren't what you do in medicine, right? Because healthcare is more broad than that. I think that's where, to Corey's point, when you're doing prevention, it's like, yeah, that's the prevention stuff, right? And it's not that critical, but that's really, at this point, what we're finding is that's really going to be the answer. Otherwise, we're going to be in real trouble as a society, right? As far as community health workers, I just learned about them a few years ago through a colleague of mine that was doing some advising for me. And literally, they are the foundation for our business model, especially when we're dealing, because we're focusing on corporate wellness, right? Because as you pointed out, most corporate wellness programs don't work. And the main reason is why there's no relationship, right? I look up corporate wellness programs, and the top 40, they're all apps. So it's like, there's no human interaction going on. And then the HR people that are responsible for running that program, that's not what they do. So it just doesn't get involved in it, right? And so the community health worker is that person from a mindset standpoint that understands how to really engage people. And that's really our philosophy, is first you have to have a relationship to get people to change behavior. Right. So I love that. The challenge that we see, one is you have to have in order to charge technically from a insurance billing standpoint, you have to have a medical professional supervising, right? But as part of a wellness program, I don't think that's necessarily the case because you're just paying for the wellness program. So I think from our side, that's really the angle. The one concern I have and question that got brought to me from a community health worker is, but what, I don't want to work with corporate people, right? So can you touch on that? And I think you mentioned some things that I think I can use to help, I guess, combat that as far as who within the organization, but then it's like, now are you picking and choosing who people are helping, and that could cause an issue as well, perhaps. From people feeling like they've been left out. So do you see how that, do you have an idea of what that might look like? Or have you had any conversations, or anyone that's community health worker, what's your thought as that kind of gets brought up? So thank you.
Thanks, Andre. I can answer that from my own standpoint, but Corey or someone else may have better thoughts from the perspective of a community health worker. My own hope is that this is about the employees more than it's about the employers. The private sector is such an incredible driving force in our society, and that can be both for good and for bad. I think we oftentimes assign judgment or value that is, universally we do this, right? We assign value based on our own experiences and what our perceptions are of others. I don't, in my own experience working with businesses, I find that most of the employers that I have met with really do have their employees' best interest at heart. Having said that, not all do. And so the hope that I would have is that we would create a space where the community health workers really are interacting with the employees, where there is a third party, a community health worker organization, for example, that is the interface with the business, so that any of those concerns would hopefully be mitigated by that cushion. But again, I don't have the lived experience. I'd love to hear from Corey or others if you have thoughts about other ways of potentially softening that relationship.
Yeah, go ahead.
I'll say one thing and then we can move on to a different question. I think with that, that's part of what, I saw our role as a company, right? Because whether you're a community health worker or whether you're just a fitness advisor, a nutrition person, you're super excited about dealing with people, not finding contracts to do the work, right? And so those need to be separated out so the people that are about the people can do that work, and then those of us that are into sales can go talk to people for them, and then we all do what we do best, right? So I appreciate that. Again, I'll connect with you one-on-one, and I just appreciate the work you're doing, and thanks again for your time.
Thank you. I look forward to connecting.
I see some good chat going here around the American Rescue Plan and a $7 billion earmark focused directly in this space. Jeremy, thanks for your insights there. Not to further muddy the waters, perhaps, but my understanding is that this is, a significant amount of money, obviously, but my understanding is that it doesn't, and like any government funding, there's not the sustainability of that funding necessarily addressed in that. I'm not a policy expert by any stretch, and would look to the knowledge in the room to go further into that. But obviously, significant attention is now being refocused to this space. I don't know if Jeremy or Eric would want to chime in further, or others, but that's obviously a huge trend that we need to keep a pulse of. And Nina, thanks. Yeah, all roads point back to California, it seems, with many of these models. And Corey, I think you came off mute.
Yeah,
there.
I was just going to say that I think that's a really important part or thing to point out, Nick, is that, any of these grant programs that help incentivize or create these new ways to pay for public health staffing, in particular, community health workers are always welcome and wonderful. But yeah, that sustainability issue is a challenge. And I don't want my comments either to detract from, I love what's happening here. And is an excellent presentation, Dr. Frank. I guess, it still just kind of leaves me kind of wondering, I can see that, or I guess I heard in your, some of your closing remarks there that you'll be using claims data as part of, kind of evaluating the pilot. I guess I just kind of wonder if you can speak more to kind of how you will kind of track these, this engagement, or however you want to kind of phrase how the community health workers will be working with employees, and tracking of kind of what social determinants they'll be addressing, and any kind of interventions that will be provided. And then ultimately, again, sadly, it kind of comes back to like, well, how are we paying for this service? Is it kind of, where we've seen some work around looking at preventative care and kind of more the value-based payment system, where we're seeing kind of an overall reduction in cost, and we're using that to offset? Or, I guess I'm still kind of left wondering, like, how you envision kind of building this model from, the three potential ways of looking at how to structure this or place community health workers. I'm still kind of not sure about kind of the logistics of how this works in this setting.
Well, I have the good fortune to have not developed the pilot yet, so I can really say anything I want. But honestly, you're bringing up a lot of the challenges, right? I mean, so initially we went into this from a healthcare's perspective, right? Like, can we dig down into claims data? Can we show that there's a decreased ER utilization? Can we show that there are, improved blood pressure, blood sugar, things like that? I can't tell you that that's going to be the best way to do this. I do think that there has to be a business case made. In other words, there has to be a return on investment for these services if other businesses, other companies are going to want to invest. I think that can be done in a lot of different ways, including what we call soft, outcomes like employee satisfaction, turnover rates, even productivity. There will be a number of stakeholders, as I said, who will have input into the metrics, not the least of which will be the employees themselves and the community health workers. So I think all roads are open. With regard to the question about funding, initially, I think this will likely have to be a grant-funded process. My hope is that we will develop a model that is attractive to businesses that can then invest in the same way that they would with an EAP, or perhaps they take their EAP dollars or their workplace wellness dollars and they invest them in community health workers instead. If I can look 20 years in the future and wave a magic wand, this would be one way of having community health workers be more integral, more sort of center stage, if you will, in helping communities where they live, work, and play. In the now, you mentioned value-based payment. We're doing a lot of work in the state to try and figure out this exact question. How do you pay for community health worker services? There's clearly a value. Is it through just giving lump sums of money to providers rather than paying each provider for each visit that they have with an individual patient? The idea being that you can then innovate better because you have more capital that you can, more upfront capital, or reimbursing providers for outcomes rather than office visits. I think those are all innovative and potentially helpful ways of paying for community health workers in the healthcare setting. I don't think it does I don't think it accomplishes the goal of moving a lot of these things back into the community where they really belong, right? Where, to Andre's point, healthcare often gets translated to medical care, and I think we are as much at fault as anyone for that. And we don't necessarily have the right or the business of trying to provide housing, trying to provide food for communities. I think the money would be better spent instead of $17 trillion on the healthcare system. Could we take some of that and reinvest them into communities? So I think basing community health workers around the healthcare system runs the risk of continuing to centralize the healthcare system rather than the community.
Well said.
So
Well
this,
said. Oh, go ahead.
Nick, this is Suzanne Swadner from the Healthcare Authority. I joined late. I apologize.
Oh, welcome.
I have a couple of comments here that are going to kind of build off of my colleague Corey's questions. So I work at the Healthcare Authority, where our job is to be the Medicaid state agent and the employees benefits state agent for healthcare insurance. With that as said, I think that what we would agree with very much in what you just said is that we do not want to over medicalize this profession. That while changes and impacts on individuals for things like A1C and diabetes are important, the question becomes, what's the purpose of having the community health worker in the team? What role and function does the community health worker play in the team, and how do we measure that? Not how do we measure and shove them into a model in which we're already measuring a number of times under value-based payment outcomes and attributing outcome savings from outcomes on A1C, et cetera, to other interventions. My other big worry, having worked in healthcare a long time, and my white hair is just showing on the top because I'm sitting in a weird chair here, and you primarily see the top of my head, which is my best part. You don't have to look at the rest of my face, but my white hair will tell you that we've been doing this a long time, and what I don't want to do is memorialize what we already know how to do. What I want to do is to have a conversation and dialogue about how we can take the system and make this role and function able to not justify itself, but to identify the practical inputs and aspects of the work on where we go. And I think what happens, being the folks who own the employee piece, we often will say, well, community health workers aren't relevant to employees. And I say, if you're a bus driver in the school district, you have probably weeks you can't feed your kids. You probably have weeks where you have housing instability. All of us have social determinants of health issues. So community health workers are relevant for all of us. So if we can kind of find a way to make the determinants that we measure not just be about Medicaid, not just be about employees, but be about sort of the role of healthcare, of community health workers in bridging the community and the health system, that will be a plus. And I know there's a number of places that work is going on that you're probably in touch with. The Siren Project is a big one that gets discussed. I also would advocate for the fact that when we talk about creating a reimbursement system, that we don't just recreate fee-for-service reimbursement, where we take and we try to identify a structure for the community health worker and we give them a CPT and we give them $25 for doing that work. But that we find a way inside the larger reimbursement that we give to providers who are using these folks, and they're typically, in our state, the folks who are currently using CHWs in their health system most commonly are FQHCs and CHCs. That we find a way to incentivize providers, and some of our largest providers are getting incentivized to put this role in place in very targeted ways, but to pay them in a way that identifies the importance of this worker. And it doesn't necessarily mean you give the widgets of 5 units of service to that person, but that you have a pool of money and you demonstrate the impact of the pool of money on the people who work within that pool of money. So it's a value-based payment approach rather than saying, I know how to do capitation with these folks. It's how do we integrate them into an approach? And I'd be interested in continuing that conversation, because I'm sure we're all sitting here with the conceptual idea that that's the way we want to go. And it's the hard work that you're doing to say, how do we do that? So we hope that we'll be able to kind of continue to have a dialogue around that. And I'm just excited that we're thinking about that. So those are a couple of pieces. Here in Washington State, we have work going on to develop what I believe is being called the Community Health Worker Alliance, which could be some of what you described earlier that I kind of entered in on. So I only caught half your conversation, so please let me know if I speak out of turn. But they would be kind of the intermediary between the employers and the CHWs as a whole. I'm a nurse by background. It's like having the Nurses Association. They can be that intermediary and very much inside the CHW role. And Corey can help me if I go off base because she's been in the same meetings I have for the past 4 years. Inside the CHW role, they really want to represent and be involved in and engaged in the idea of how their profession grows and changes. And so we have a really good opportunity to talk to CHW Alliance and say, here's what we're trying to do. And here's what we're going to do. We need to be clear about that there's limits around how we do it, but what are their ideas about how they can engage their role to help form this intermediary that you see happen. But things are moving fairly quickly at getting folks integrated because of COVID.
Suzanne, thank you for those observations and comments. I want to certainly give space for a response. If Dr. Frank, you might want to comment. It's certainly an important thread that we'll have to continue offline here, Suzanne. Thank you for elevating that. So Dr. Frank, if you'd love to respond, and then I'd love to come to Catherine and then to Nina. Nina informed me, Catherine, you had your hand up first. Thank you for your sense of fairness there, Nina. We'll come to Catherine and then Nina, but first, Dr. Frank.
Sure. I mean, Suzanne, you raised a lot of great points, and I think in my experience, this conversation that we're having is really about how do we help people be healthy, and what do we value in that process? And I think for too long we have said it's an individual sitting down with their traditionally doctor and talking about clinical issues, solving problems one at a time, often with medicine or other interventions. So that we know that doesn't work, right? That's not the way to get a population healthy. It's not a way to keep communities healthy. So I think the healthcare system has to reevaluate its approach to health. It has to reevaluate the way in which it interacts with communities. It has to evaluate the power differences between the healthcare system and the community and figure out a way to shift some of that power back into the community where they are experts at what will help them be healthy. And I see community health workers as a critical link in that transformation. How we get there from here and how we do it without consuming the community health workers into the behemoth of the medical system is a challenge. And I think it's one that we really have to be cautious with. So I don't know that I have all the answers, but I do agree that that the sorts of changes that you're talking about really have to take place.
Thank you, Dr. Frank. Catherine, over to you.
Hi, Dr. Frank, and everyone that's joining in today. I just had a few questions regarding if you may be working with some of the international community that is engaged with community healthcare worker models, and if there may be models that they are utilizing that may be applicable within the U.S. healthcare system, where we don't have things like universal health coverage. And then I wanted to go back to one of the slides that you showed, looking at employees that would utilize community healthcare workers. And I'm wondering if there was a specific subset of specialties that were less likely to engage with community healthcare workers. And what are some of the ways that you feel that the community that's involved in this could approach those clinicians to perhaps become a little more interested? Like, for example, patients that may be undergoing surgical procedures that may need post-operative care management and then are discharged. Could they help with follow-up and reintegration with family practice doctors for continuation of care? Those are just some thoughts I had off the top of my head I was wondering about.
So the issue of the groups that are or aren't interested in working with community health workers, we really divide it up by their job category, some of their self-identified demographics. So it's less, we didn't delve into medical issues or medical needs in our survey. I do agree that community health workers can be beneficial across the spectrum. I think that, one thing that's most important is that it's the relationship that drives what they focus on, right? It's the relationship between the community health worker and the individual and their family that drives the focus. So if there was an employer-based community health worker, it would be up to the relationship between the CHW and the employee to determine where that would be most useful, which speaks, I think, to some of the challenges of doing that within the healthcare system, right? Because we have our own agenda, right? We're worried about when this person comes out of surgery. We're worried about whether this person is taking medications. We're worried about them getting this test. But that may not be at the top of their list, right? It may be, how am I going to take 5 buses to get to my appointment? Or, what happened to a patient of mine the other day? His ride fell through. So he took a cab to the hospital to get a procedure that required sedation. And they said, well, we can't do the procedure. You don't have anyone to drive you home. Right? Well, this is a person who a month ago had a bleeding ulcer and was admitted to the ICU and really needs this procedure done, and we are focused on a very narrow window. So I think I've gotten off track a little bit, Catherine, and I apologize, but I think it's more about the relationship defining the need than it is about us predetermining what they would be doing.
Thank you, Dr. Frank.
Thank you. And Nina, finally now to you. Thanks for your patience.
Thank you. I really love this topic. It's really engaging and nice to meet you all. The first thing that comes to mind when I hear about what you're trying to do is the culture of each employer, because I don't know if there's a one-size-fits-all approach, and I wanted to know your thoughts on it, and maybe other people who are CHWs here can tell us a bit more about if this is something that's come up and how they address it. And second of all, I'm following what the state of California is doing with regards to CHWs, because I know everyone's been interested in implementation and making sure that this can last and not just be like a temporary stopgap thing. But in case anyone's curious, in a nutshell, the state of California is implementing a statewide Medi-Cal program that's going to be uniform. Previously in California, all the programs are very different within each counties, within each community, but it's going to be statewide, and the CHWs will play a very, very, very important role, especially for the most vulnerable populations. So just anyone who else wants to follow this trend, I think is really interesting. It's something to see how it's really interesting to see how it plays out. But back to you, I'd love to know more about the culture of these employers, and the fact that my impression is that there can't be a one-size-fits-all approach.
I think you're absolutely right. We're fortunate in that, OHSU is interested in the results of our research and willing to help us, develop a pilot. At this point, as I said, we don't really even know what this pilot is going to look like yet. But you're right. I mean, there is no one size fits all solution. So I think it'll be interesting to see if we have success with this model, what other models can look like.
So just monitoring our Slack or our chat here, Mary Beth, you asked a similar question here to Nina's thoughts. I don't know if you wanted to add any context to what you're thinking there, what you're working on, but not to put you on the spot, but just wanted to make sure we had that continuity.
Yeah, this is a two-part question. I'm interested in knowing how people view the challenges to sustainable payments, and I guess around that, sustainable engagement of community health workers. Obviously, a funding source is important, but if we're taking this in the context of value-based care and also moving the needle on outcomes, I'm curious how people see that, and if there were any additional insights around the Medi-Cal changes for CHWs, that'd be great.
Thank you for that, Mary Beth. Yeah, I don't know, maybe no other answers in the room today, but I think you're raising, kind of the cutting edge questions that we still need to unearth in this context. Nina.
Oh yeah, I was going to say, California's new program is based on this health homes pilot and its whole person care pilot that it launched in various counties. And there's some, I'm happy to send anyone a link to the health affairs article about it because it does a very good job of evaluating the outcomes. And they found the reason they have CHWs rather than the reason they have CHW is that they found that people need high point contact as they get needs in the community. They can't do it on their own. They need that outreach. It may be a little bit hand holding, but that outreach they found is very important.
Thank you, Nina. And I want to really elevate and thank you for the offer of that link. Corey, you elevate an important question I want to amplify, and Dr. Frank touched on this in the presentation, but to the community health workers in the room, we'd certainly love to hear from you. This conversation, it needs to be centered around you, obviously. So please, any thoughts, reactions, just feedback in general from this conversation or just your lived experience in this space, we'd love to hear from you. And just a housekeeping note, we'll take all the links shared here in the chat and put that in our follow-up email that we'll get out tomorrow. So no need to take that and save it someplace. We'll follow up with a recording to this conversation as well that I started maybe 5 minutes, 10 minutes into our conversation. My apologies for that oversight there, but we'll be sharing that with the room later this week, early next. Well, in absence of other questions, I will lob in just kind of a thought, and this is in the context of Cambia Grove, we're not prescriptive in how these approaches ought to be achieved. We're here to have the conversation and try to put multiple perspectives on stage and put this in the hands of you, the innovators. With that though, there's a podcast that I've just been plugging for the last week. It came up in our member Slack chat. Sarah Gallo, as some of you know her, put this in our Cambia Grove member chat. And as I try to find it, it essentially, to me, gets to kind of the larger structural challenges that we're ultimately talking about in this room, and the opportunities here too, specifically around linking value-based care and health equity, right? As we know, a budget is a list of priorities, and if health equity is not tied to value and it's not prioritized in a monetizable way, you're not really delivering in a full effect. So this podcast, it's maybe 30 minutes, really gets to a lot of the core considerations, especially some of the policy ones that override this conversation and create a lot of challenges for us as we think about scale. So anyway, I'll put that in the chat here as soon as I find it.
I wanted to answer Corey's question from the chat about Familias en Acción, which was the community-based organization that advised us. They were great in providing recommendations around ways of potentially structuring this, the idea of making sure that there's training available, make sure that there's support available. They also pointed out that it's important to work with community health workers who share some similarities with the employees they'll be working with. So we actually, there are some community health workers, at least in the Portland area, that are members of the same union that serves OHSU. So, potentially partnering with them as far as more specific recommendations about the model, we have not gotten to that point yet. I would echo, Corey, your question. If there are other community health workers in the audience right now, I'd love to hear from you if there are things that you think are potentially beneficial about what we've talked about, or if you think that we're way off base about anything.
And feel free just to jump in the chat or raise your hand here. But I see my colleague Laura, your hand is up. Would love to come to you. Oh, might be muted there.
I'm muted in 2 places. Okay, thanks, Nick. So I see, Angelina, you are a community health worker. I know we emailed. I'm happy you were able to join today. I'm curious, Dr. Frank and others, for organizations who are thinking about engaging with community health workers, like this practice that Angelina is working with, who had never worked with one before, what are some next steps that organizations or teams can undertake as they're considering going down this path?
I'm happy to jump in. This is Eric.
Yeah. Hey, Eric, thanks.
So I'll jump in with a few comments. So, some of the things that I heard today really resonate with me. And I think for me, I think there's plenty to say around like fee for service and what that does, and especially when it comes to marginalized communities, right? The fact that, our healthcare providers are incentivized to see people in high volumes versus really spending time. So that was one thing that came up, and that really kind of leads me to the concept that, obviously value-based care, there's a lot of people talking about it. We hear a lot of companies really focused on value-based care. And then there's a whole concept around just like patient consumerism. So those are 2 themes that I think are really important for me. And when we think about how we address the needs of these marginalized communities, I think the community health worker plays an important role. And we certainly want to make sure that we don't get into a situation where we over-medicalize this role. I think that in this capitated model where you're getting a PM, I think there's certainly ways for you to really kind of finance the business model that supports using community health workers. I think what's really intriguing for me is that, if there's already provider shortages, specifically like for the Latino community, which is what I'm focused on, what better way than to help sort of fill that gap than with community health workers that are people who have the same shared and lived experiences. And so for me, I think coming up with models that really address these gaps and really align incentives around, outcomes and relationship building and really earning trust is going to be really important. And hopefully we'll see more and more folks adopting this model so that we could continue to leverage community health workers. And I think community health workers in our communities as well, like this is a great way to also create jobs. There's a lot of impact if we could provide the training, if we could provide opportunities for people in the community to help the community just live healthier lives, right? Both on the social and healthcare side. So just a couple of comments there around what I'm hearing and some of the things that I think are a little validating when it comes to approaching healthcare a little differently.
Eric, thanks for that. And I'd love to come back to the question, Eric, and this breaks kind of a protocol that we have at Cambria Grove, and that's that we don't do a ton of just highlighting of individual solutions or their approaches. So I just say that because I'm excited about this topic and we need to be having this conversation more directly. So to you, Eric, and this is a question we ask of Dr. Frank here too, and maybe if we have time, we can get into his answer as well. But Eric, what's your biggest barrier today in advancing your solution? Please give an overview of that solution if helpful. I know you're in earlier stages perhaps, but what's the biggest barrier that you and your team are facing right now?
Yeah, I think it's so just by background, I mentioned in my introduction, I worked at Amazon, right? And so at Amazon, I had brand awareness, right? Everyone knew who we were, what we were doing, could definitely get people's attention. Now that I'm outside of Amazon doing this on my own, it's really just getting the support. And I think that there's a lot of people that are interested from an investor perspective, providers, we've got community leaders, grassroots organizations that want to see this happen. but it's definitely going to be a very, ground up approach that we're going to have to take. And the challenges are going to be really just being able to find where to focus, where to build sustainable business models. I think there's a lot of folks that have focused on like Medicare Advantage, right, and taking capitated risks there. But my real desire here is to help build solutions for our Medicaid population. The employer opportunities that were discussed in this roundtable were especially interesting as well, because there are a lot of employers who have these employee populations that can be right. Maybe they're underinsured, maybe they're not paid enough to pay for their healthcare, and so there's just going to continue to be these socioeconomic challenges that people are going to face when it comes to consuming healthcare. And I think that, again, just really, really bullish on the concept of community health workers to help fill that gap. So I won't say too much about what I'm specifically working on, but it's just really that it's being able to build a model. And right now the challenges are going to be what any new emerging company is going to face, which is just to make sure that we have all the appropriate stakeholders and focus on the right things when we have these limited resources to begin with.
Eric, thanks for saying that. Quickly, and Aaron, so glad to see your hand come up. I was going to come to you with a question here too, and here's just a plug that I would say at the half-hour mark, but I'll just say it now. This platform, obviously connecting in this room is a big piece of what we do at Cambria Grove. We have this Cambria Grove membership that I know a number of you are members of. We need to connect dots in this space, right? That's ultimately what's going to drive a lot of these conversations forward and lower those barriers. I'll put a couple links that'll be in our follow-up tomorrow. This is a free membership. We're non-revenue generating, so you're not getting upsold anything, but it's really about meeting the right people at the right time in your efforts. So more to come on that. With that, Aaron, would love to come to you.
Sure, and I saw Suzanne's hand was up too, but you got your question.
Oh, sorry,
answered.
yeah, Suzanne, I didn't see it. You seated back down. Aaron, I think you're probably segueing from Eric more directly, and then Suzanne will come to you after Aaron.
Yeah, I guess I wanted to build off of what Eric was saying. My main question for Dr. Frank was sort of what is the vision for after the pilot program? So is it the goal to develop a CHW program within OHSU that serves OHSU patients only? Is it to develop like a startup that's a spin out of OHSU working with lots of different employers? And if so, kind of getting to Eric's question, like how do we address individuals that are unemployed? Is that just sort of an entirely separate population that's going to require a different approach? And not that employer-based solutions aren't important, they certainly are. What are we doing about everyone who can't be reached through employer-based solutions?
It's a great question. The focus of this pilot, or the idea behind this pilot, was the recognition that there has been a lot of energy around making community health workers available to low-income, uninsured or underinsured individuals, which I think does a disservice to and really like perpetuates a lot of the misunderstandings about poverty, which is just because you have a job doesn't mean that you have sufficient insurance, doesn't mean that you can take care of a lot of your needs. And so the hope behind this is really to engage the business community, to develop a model whereby employers can begin to understand the needs of their employees, to understand how the business community at large can play a powerful role in changing the trajectory of a lot of the inequities that we see, and really just helping to meet the needs of their employees. So I agree, it does not address those people that are uninsured. That, to be transparent, was not the goal of this particular program. But I do hope that if we find another avenue through which community health workers can engage with individuals, with members of their community, it begins to normalize the process of, again, putting the power back in the community to identify what their needs are and come up with solutions for meeting them that then can be supported by entities that hold greater financial power without the solutions being developed by those with financial power.
Yeah. Wonderful. And I'm just being mindful of our time here. We do have 5 minutes remaining. So I think we probably have time for one more question from Suzanne and then an answer and maybe some final comments then from you, Dr. Frank. We'll give you final word there. I'll get out of the way and just simply say my thanks on behalf of Cambia Grove and the community here. We stand here in support of you and these conversations. So just please let us know what we can do to help further the cause. We'll follow up again with more of a recap, links, and just offers to continue this conversation. So look for that from us probably early next week. Suzanne, would love to come to you for our last question today.
Yes, and I'll do unusual things, which is to speak quickly, but I'll be brief. The first thing I want to say is to kind of follow up on the conversation that we just had with Dr. Frank about using the employer as a base. I would remind people that most unemployed people are eligible for Medicaid. So by definition, if our goal is to see the community health model built out and deployed in Medicaid, which is an important place to put that model, most unemployed people will be in there. And a lot of employed people are also in Medicaid because of the range in which they're paid and the fact that they can be eligible for subsidies. So I think we shouldn't think about this just as an employer versus Medicaid solution, but we should think about it as where's the site that people are going to get reached in this marginalized populations that we're interested in. I think about our health benefit exchange population. I think that big employers still have people. I mean, I mentioned the bus drivers at the schools. There are folks who work at Amazon who are eligible for health benefit exchange. It's not safe to say that all employed people have adequate coverage and coverage that's going to meet their social needs. And that's kind of that little thump I'd make, which is let's not rule out employers as a good place to try and experiment, because we need to find good ways to deploy CHWs across the settings that they're in, their populations are in. I think my second question was really kind of just to reiterate for all of us that I'm really interested in this concept of how we're doing this around payment, and that what I go back to in my stress and my function is that we build a model like Dr. Frank is doing that's about the functions that should get delivered and not the way we pay people. Way too interested, given my long history and given the fact that I work for a public funder, to say we want to be paid and to build a model for services around how to pay ourselves, instead of to build a model of services around what we want to pay and then determine how best to pay them, what we want to deliver and then determine how best to pay for that. So just to make that push a little bit, that we consider funding important, but that funding is not the driver. The services we're delivering to the people we need to deliver to should be the driver.
Thank you, Suzanne. Dr. Frank, in our 2 minutes remaining, we'd just love to give you final word. Any ask you might have of the community or what to be on the look for as the pilot progresses, anything you'd like to leave us with?
So much pressure, so much. So Nick asked me this when we talked last week. What is my ask? And I didn't have a clear answer. I'm not sure that I do now, other than to say that whatever it is that you're doing, wherever you're working, whatever the project is, you clearly have an interest in what we've been talking about today. At the heart of it for me is pushing, is empowering communities to identify their own solutions, to identify what works for them, to identify the ways in which they get their needs met, and give them the freedom and the opportunity to come up with those solutions. So whether it is engaging community health workers in the business place, whether it's through the healthcare system, or if it's unrelated to community health workers in general, we need to trust that communities will come up with their own solutions and that they'll be the right solutions for them. So I think my ask would be, whatever it is that you're doing, figure out how you can help build that trust for communities to develop their own solutions. And then how do we support them, whether through policy or finance or any other mechanism?
Well said. Perfect way to conclude this afternoon's conversation. Our thanks again for your time and talent in this space. We're here to support it as the conversation continues. Look for more from us and let us know how we can be of service to you. Dr. Frank, thank you. Thank you, everybody.
Thank you all very much.
Thank you.
Thanks, everyone.